Well, hello and good afternoon, and thank you for joining the fifth meeting of the All-Party Parliamentary Group on Axial Spondyloarthritis. I'm Tom Randall. I'm the Member of Parliament for Gedling, and I'm just standing in for Derek Thomas this afternoon. Thank you so much for joining this online meeting, which enables us to meet from the comfort of our offices and living rooms across the country. It's the meeting. The theme of this particular APPG meeting is going to be on axial spa and hydrotherapy, and exploring the provision and improving access to hydrotherapy. And I know that hydrotherapy is an important tool in helping to manage axial spa, and there's lots of concerns about the service levels across the country. What we're going to have today is we're very grateful to have 4 expert presentations that will help to provide a range of key perspectives on hydrotherapy care and axial spa. And as part of these presentations, we'll also be presenting the results from a new Freedom of Information Request programme that will be providing the latest available evidence around plans for hydrotherapy care and how COVID-19 is impacting on these pools. These presentations are going to run, I think, till around about 5:45. I do apologise, we're starting slightly late this afternoon. And after that, we'll move on to a question and answer session that will be facilitated by Dr. Dale Webb from NAS, who I'm sure you all know. We encourage as many of you to get involved in the Q&A, and please do enter any comments and questions you have on the topic in the chat tab, which you should be able to see on the screen next to you, and we'll come back to these in part 2 slightly later on. So what I propose to do is move on to the first of our 4 speakers this afternoon, and the first one is Peter Kellythorne. Peter is a NAS member, and we're very grateful that we take him through his own experiences of hydrotherapy care in his local area. Peter.
Hello, I'm Peter Kellythorne. I have axial spondyloarthritis, and I'm here to talk about the benefits that I've experienced from hydrotherapy, the physical benefits, the mental benefits, the effect of having the pool closed that I was using, and the procedure of which the pool was closed. I first experienced hydrotherapy on a 2-week residential course with the Royal National Hospital of Rheumatic Diseases in Bath, where we had hydrotherapy every day. The benefits were superb. My condition improved greatly, my flexibility improved, my pain reduced. So after the course, I obviously wanted to continue that. I found that a hospital local to me, Bedford, had a hydrotherapy pool. So I started attending there. And initially I had a course as a NHS patient, but you only receive 6 sessions within 2 years as an NHS patient. So once that finished, I continued paying privately. I mentioned the physical benefits were a reduction in pain, which meant I could reduce my medication, meant that I was sleeping better at night. It also improved strength and flexibility, which also improves balance, which helps older patients. And these are all reasons why hydrotherapy is a recommended treatment by NICE. Benefits of this are quite far-reaching. The longer sessions that you have with hydrotherapy mean that you have more time to discuss with the physio any problems that you are having, and any issues that you may see that are coming up, as well as just talking about your general well-being and your experience of the condition, and they can give you tips and you can give them tips to pass on to other patients. The main part, though, for me was the reduction in pain, particularly in the pool. That provided a little bit of respite, because when you have a chronic illness where you're in pain 24 hours a day, 7 days a week, and you've had it for 20 years, like I have, that bit of respite is vital, because it's the only bit that you get that isn't replicated in any other kind of therapy. The improved sleep aids your general well-being, which then just feeds into everything. Everything's a little bit better if you've had a good night's sleep. The effect of closing the pool took all of those things away. So it was quite stressful and quite worrying when it first happened. The increased pain levels meant that on occasions I had to increase my medication. When I had flares, they took longer to recover, which means more damage is being done to my body by the condition. The recovery time from those also increased. All this led to increasing anxiety and depression, which I now have to take medication for, which I didn't have to before because everything was managed. The closure of the hydrotherapy pool was stressful. I had no advance warning. I arrived for a hydro session and was told I'd be the last person using the pool. The physios had been informed that morning the pool was closing, and they couldn't offer me any alternatives as a private patient. Some of the NHS people were later offered hydro sessions in a pool in a nursing home, which wasn't open to the general public. And also means that now, during COVID, there's no hydro at all. The Bedford Council Health Overview and Scrutiny Committee were not informed about the closure of the pool. They found out from a tweet by a local newspaper. The hospital seemed very reluctant to engage with patients. In the end, a consultation was started, primarily because of pressure from patients and Bedford Council. The consultation itself was flawed. Private patients weren't included initially. As a private patient, I had to contact them directly to get the paperwork to be involved. The information provided by the hospital seemed to be quite skewed. It was provided to the Right Honourable Mohammed Yassin. It was saying that the pool was in worse condition than it appeared to be to me. The main issues with the boiler, the changing rooms and the pool themselves were perfectly serviceable. The consultation itself seemed to be a bit of a box-ticking exercise that they were forced into doing, following the process correctly. It always appeared that the decision had been made. Speaking to other patients through the consultation process, they all found that hydrotherapy was a massive benefit to them. They found that there were aspects of hydrotherapy that they couldn't get from any other kind of therapy. And like me, they were having to start increasing medication, and they were worried about the long-term effects of this, and worried about whether, as things were obviously getting worse for them, what future interventions they would need, whether that was increased medication or surgery. The other problem that's arisen from this is that waiting times for land-based therapies have increased due to the extra demand because there's no hydrotherapy. So that's my experiences with hydro. Thank you.
Many thanks, Peter, for a really important presentation. We'll come back to that later on in our discussion. Our parliamentary colleagues are being called into the Parliament. It's a very busy day today with numerous votes, including those relating to coronavirus. So I'm going to temporarily step in as chair for the meeting, and hopefully Tom and Derek Thomas will be returning to us very shortly. So we now move to our next presentation. It's a great pleasure to welcome Dr. Carol McCrum, who's joining us. It's the middle of the night in Australia, and she's joining us for a presentation about the evidence and research underpinning hydrotherapy. Carol is a consultant physiotherapist. Carol, welcome.
Hello, my name is Carol McCrum, and I had the honour of being on the nice guideline for spondyloarthritis, which included us working on learning about the effectiveness of hydrotherapy and its value for managing people with axial spondyloarthritis. So today I'd just like to talk to you about that experience of looking at the research since, and just to help understand a little bit about the decision we came with, the recommendation that we could make, and what underpinned that, and going forward from that and since. And so just to start today, as a NICE guideline group, we had the opportunity to ask and have people help us search for research that tried to answer a question that was on hydrotherapy, which was, what was the effectiveness of hydrotherapy compared with standard care for managing spondyloarthritis? So we covered all the different kinds of diseases that incorporate spondyloarthritis, and that included axial spondyloarthritis and AS. We were looking for anything that compared hydrotherapy against a control, standard care waiting list, delayed start, no treatment or placebo. So anything was included, and the outcomes that were searched for, thinking that they would be useful as a judgment of effectiveness, were outcomes such as pain, harm, effects on mobility and function, quality of life, and other measures that help us determine whether we're making a difference in people with AXSPA. So what did we find? Big search, found lots of articles, of which most weren't relevant or suitable as a source of evidence for it. So it came up with 5 RCTs and 7 observational studies. So there was one RCT on what we decided was active hydrotherapy, which involved an exercise component. And within that one RCT, it was of interest because they had a combination of therapies, including a physiotherapy-led group session, and that included a heated mud pack to the spine, a thermal bath tank session for 10 minutes, and then the hydrotherapy session. Especially interesting because it was done in a thermal mineral salts pool, specifically from a well. So the other kinds of research that we also included, which had anything to do with being in warm water, and that included 3 RCTs that used heated baths, mineral salts, and for some people in one study, using an electrical current as well. And there were another 7 studies that were observational, which included a questionnaire, a survey that was done annually here in the UK of people undertaking hydrotherapy, other observational studies that looked at the effectiveness of warm bathing and mud packs, and also hydrotherapy, which was often part of a combination or component of a complex intervention, so one of a multiple intervention approach. And then more recently, there's been a systematic review published earlier this year, which looked at 5 studies, and they were using their AS patients as their participants, and we're looking at benefits on the bathing disease and pain. So what did we find? So just a little overview of the summary of the evidence. Unfortunately, for helping us make a decision for hydrotherapy, nearly all the studies were considered from an evidence hierarchical point of view of being very low quality evidence, and most of them showed no significant difference for any of the outcomes. So for passive hydrotherapy, nearly universally showed no significant difference, except one study showed there was a small but significant difference for the group that were in a heated bath with an electrical current. And there were very small improvements in the bathing disease and in ASQOL. There was evidence for interventions that had hydrotherapy as a component, and that showed an increase in quality of life. And I guess very importantly for us, there were no reported harm to adverse events. But there were a lot of challenges with the research. So particularly with the participants, most of the participants had really long-standing established disease, which might make a difference to what kind of effect you might get with some of the outcomes, particularly about some of the mobility outcomes. Most of the studies were quite old and they predated some of the measures we used, such as BASDI and other outcome measures. Often the outcome measure was looking for an improvement in these people. So long-standing disease, AS, as opposed to, so already with quite established changes, and they were measuring improvement. And so there wasn't anything looking at whether people maintained their mobility or actually reduced progression. And that was partly because none of the studies had any long-term follow-up, which might be really helpful and important for looking at the value of hydrotherapy. Thinking about the kind of interventions they used for their hydrotherapy, we needed to make sure that any studies we included had some representative value for the UK and in particular for clinical practice within NHS. And so that really limited the value of some of the interventions that I mentioned previously. And there was no economical evidence that we could use that supported the question about what was the cost effectiveness of it. So we were able to come up with a recommendation, and one of the important things for NICE is we can't recommend anything where there's not good evidence for or good cost effectiveness. So you'll see in the first recommendation that was made, it was able to be worded that that people should be referred to a specialist physio to start an individualised exercise program. So much stronger language. We were able to include a recommendation, and we could use the word consider to consider hydrotherapy as an adjunctive therapy to managing pain and maintaining function. Off the back of very low quality evidence, and particularly off the back of the UK survey, annual survey that was done, that very valuably took the views of people that were having hydrotherapy, and they reported the significant benefit that they felt it made. So that was very, very helpful. From that, because of the lack of research, in the NICE guidance, research recommendations were made. And there were 2 research recommendations made for spondyloarthritis, which encompass AXPAR. And the main one really was looking at what we tried to look at, what was the short and long-term effectiveness and cost effectiveness of firstly improving patient-reported outcomes in spondyloarthritis. And it was really recommended that the reasons for that and the rationales were about needing well-conducted RCTs with long-term follow-up to capture the benefit of hydrotherapy. And then which type of hydrotherapy intervention was helpful. So the kind of exercises or the kind of things that were being undertaken in the pool. The second recommendation that we felt was really important was its role, exploring its role in managing flares in people with spondyloarthritis, and particularly AXPAR. There wasn't any evidence on its benefit or help for flares, and really it was felt that this could be quite an important benefit and definitely warranted exploring. And lastly, an often asked question, does it make any difference whether hydrotherapy is done in a warm pool with warm water or in a standard swimming pool, which would have help support decisions around affordability and access because of the challenges with maintaining hydrotherapy pools being open and using a standard swimming pool, and whether that could show equivalent benefits. So one really striking thing that came from how we look at the benefits is really more recently, since many of those studies were done, we're moving to try and make our decisions using patient-reported outcomes and things that are meaningful for the people that these interventions are being undertaken for. And really the importance of valuing patient perspective is really gaining much more focus and nearly an essential part of people's experience of interventions such as an RCT, which is really, really important to help evaluate the effectiveness of treatment, and also the kind of outcome measures where quite commonly they're using outcome measures such as MIMOP or patient experience outcome measures, which have value as well for helping decide the benefits of intervention. Other things about what's a meaningful benefit and the patient perspective is really, really important for this. And who's more likely to benefit? Not everybody will engage with hydrotherapy, and can we able to think about how we maximise the people that might use hydrotherapy pools, and how we might support people to benefit more. We're really aware that there's different ways it can be delivered, either as group or individuals. Can we get better benefit if we can support engagement and expose people to hydrotherapy or support them coming? And most importantly, this group of people often have a lot of extra-articular manifestations and challenges, and making sure we support people attending with those and enabling them to attend with those quite difficult situations, either with their skin or with stomas. So all really, really important. And going forward, something really, really important, a really important aspect to include in how we judge what evidence there is and whether hydrotherapy has value for people with axial spondyloarthritis. So now, since then, delightfully, NAS has supported some fabulous research that's tried to explore that. And Claire's coming up and she's going to be talking about the results of both those strategies to try and explore more about the value of hydrotherapy, certainly from physio and patient perspectives, and also what was learnt from the National Freedom of Information exercise that was undertaken. So delightful to being able to present to the research, and I would strongly encourage anybody who has any opportunity to help us engage in really thorough, robust research so that we can have very strong evidence to support us providing hydrotherapy to this population and to support the NHS support keeping pools open. So thank you very much.
Carol, thank you so much for that really informative talk going through the evidence and the research and looking at an evidence base. We now come on to our third speaker, who speaking to us from a little bit closer to home. It's Claire Jeffries, who is a physiotherapist clinical specialist from the Solent NHS Trust.
Hello, my name is Claire Jeffries. I'm physiotherapy clinical specialist for hydrotherapy and rheumatology working for Solent NHS Trust. I'd like to start by thanking the APPG and NAS for asking me to present to you today on a topic that is very close to my heart, and that is hydrotherapy. In my role in Portsmouth, I'm the clinical manager and clinical specialist working in the hydrotherapy department and in the pool itself. As part of my role, though, I also work for the Acute Trust Portsmouth Hospitals University Trust, where I undertake the Axial SPA biologic screening and review clinics and also the annual review clinics. So for this patient group, I have the real privilege of working with them across their whole spectrum of disease and their healthcare journey. So today I'm going to present to you the national picture of hydrotherapy service provision in England. I'd like to start by presenting to you some work that I undertook with my colleague Mel Martin in our role with the A-Stretch Committee and on behalf of NAS in 2018 and early 2019. Mel and I were attending and meetings at the time, and we're hearing stories from physiotherapy colleagues of potential threats of closures to their hydrotherapy pools across the country, which would impact significantly on the Axial SPA population, and particularly perhaps our NAS branches that often use our NHS facilities. So in 2018, we undertook 2 surveys with the aim of effectively trying to map the NHS hydrotherapy services that were available to Axial SPA patients across the UK. We wanted to do 2 surveys though to really understand from the service providers, the physiotherapists, what service provision they had for Axial SPA patients in hydrotherapy, but also, and more importantly perhaps, to understand from the service users, the Axial SPA patients, what their experiences of these hydrotherapy services were. Together, the overall aim then was to make best practice recommendations for the service provision of hydrotherapy for this patient group. So if we start by looking at the results from the patient survey, we had 250 NAS members who responded to our survey questionnaire online. Predominantly, there was a female response with an average age of 51 years and a time of diagnosis of nearly 37 years. We asked the patients to rate on a scale of 1 to 10 the benefit they felt they gained from hydrotherapy for the different symptoms of their Axial SPA. Importantly, what you can see on the chart in front of you is that every potential symptom that we listed, they rated highly as being benefited from hydrotherapy, with no symptom rating under 5 on the scale of 1 to 10. As you can see at the top of the chart, the benefits of hydrotherapy for managing their overall joint stiffness, their mobility and flexibility, and importantly, their mood or mental health, rated as the top 3 most benefited symptoms. And this is reflected also in the NICE guidance published in 2017, which recommended hydrotherapy as an adjunct treatment for Axial SPA patients. Now, as a hydrotherapy manager, I completely appreciate that we can't offer ongoing hydrotherapy to all of our patients who have chronic conditions. We just wouldn't have the capacity in an NHS setting. So encouraging patients to self-manage and to utilise local community water-based facilities is a really important part of our role as aquatic therapists. When we ask the Axial SPA patients, though, why they might not use a community-based pool, understandably and perhaps predictably, the temperature of the water in a local pool facility rated highly as a barrier to them. What I'd really like to highlight to you, though, as well, are the 2 other results, as you can see on the chart here, that these facilities being overcrowded would affect whether an Axial SPA patient would access the facility, but also importantly, that due to their condition, they felt that they couldn't access the facilities in the local community. Perhaps this is due to the fact that they may have spinal deformity and indeed the fact that they may have concurrent psoriasis, which would make them feel uncomfortable exposing themselves in a public swimming pool. Now, unfortunately, due to the time constraints that we have on the presentation today, I'm unable to feed back all of the qualitative data that we obtained from the patient's survey. If you'll indulge me, though, I'd like to just present some key statements from the patients in these very emotional and 5 themes that we found from the patients as to the benefit that they gain from hydrotherapy. So looking first at emotional well-being, the patients described that they were able to have much greater control over their condition rather than the condition controlling them when they are able to access water-based exercise. Without a shadow of a doubt, the impact of having access to hydrotherapy has changed my life. In terms of exercise behaviour, we had patients reporting that they challenged themselves more, pushed themselves more with exercise in water, perhaps in comparison to what they would do on land through fear of increasing their pain or having a flare. I'm fused and I also have osteoporosis, so have to be careful when stretching. The heat and weightlessness are wonderful. In terms of group effect, whether it be part of the NAS branch or indeed in NHS day services groups, being able to have motivation and support from others with similar condition was highly important to this patient group. Meeting like-minded people with similar problems made me feel I wasn't alone. In terms of professional support offered as well, patients highly valued having the contact with a physiotherapist or aquatic therapist in this setting who could share their expertise and with whom they could discuss any problems that they had. Before hydrotherapy, I was scared, suffering with mental health and incredible pain. The support of the physios and other patients has been second to none. And finally, the pool environment itself. Patients describe gains from the non-impact exercise and weightlessness that they achieved in the water. The warm water, as we've already heard from the previous slides, was a real bonus for these patients. Hydrotherapy is my lifeline. I have so many out-of-water exercises to do, I'm exhausted. I can do so much more in the pool. I'd use local pools, but I think I'd be too embarrassed. So I'm sure you would agree, some very emotive statements about the benefits of hydrotherapy that Axial SPA patients have. If we then look at the physiotherapist survey results, we had 100 responses from various physiotherapy departments across the country to our survey. 79 of these responses stated that they had hydrotherapy services that were available to their Axial SPA patients. 86% of these hydrotherapy services being on-site with a physiotherapy service was based. Unfortunately, however, 46% of the service providers stated that they had barriers to actually providing hydrotherapy service for Axial SPA patients. As you can see on the graph here, the highest barrier was the number of referrals into the service, so the service demand, along with staff vacancies in their hydrotherapy facilities. I think what we shouldn't overlook, though, as well, on this slide, is the potential lack of investment for the hydrotherapy services in terms of pools being closed due to maintenance or old service equipment. Unfortunately, at the time of our survey in 2018, 1 in 5 of the hydrotherapy pools were under threat of closure. Previously to the survey, 22 had been under threat of closure. And at the time of the survey, 12 physiotherapy services said that they had previously had a hydrotherapy pool, but had now been closed. And 7 of these had been closed within the last decade. So if we fast forward to 2020 and the slight glitch in our NHS service provision due to COVID-19, which had a massive impact on all of the hydrotherapy units across the UK and saw most hydrotherapy services close within 24 or 48 hours and staff redeployed to support NHS services elsewhere in their districts. So this was a really worrying time for physiotherapy services and for patients alike, as there was fear that these temporary pool closures could be used as an excuse to not reopen services or to invest in physiotherapy again and hydrotherapy. So NAS undertook a Freedom of Information request in September of this year on behalf of the APPG to really understand the pre and post-COVID hydrotherapy service provision again in England and the impact that COVID-19 has had on our hydrotherapy services. The Freedom of Information request was sent to all the NHS trusts in England, and there was a 69% response rate, so representing 90 trusts. We asked the trusts whether they had an on-site hydrotherapy pool, and just over 70% said that they did. A further 15 units said that they had access to a hydrotherapy pool that would be off-site from where the acute trust was based. So in total, 89% of trusts had access generally to a hydrotherapy pool, which reflected the same results that we had in our survey in 2018. For those that did not have access to hydrotherapy pools, as you can see on the graph here, lack of funding for a hydrotherapy pool was stated in 50% of the responses. I think actually, though, this statistic may be slightly higher, as when we analyse the other responses to this question, a lack of investment in old hydrotherapy pools was documented in 3 cases, and a decision not to rebuild hydrotherapy pools was stated in 2 cases, for example, during the redevelopment of a hospital site. Importantly as well, perhaps in one of the other responses, was the fact, for example, that the expense of allowing staff to travel to an off-site facility made the cost of the service provision not viable. We asked the trust whether the pool was open prior to COVID-19, and thankfully, as you can see here, 90% of the pools were open. When we asked whether the pool would be reopening, having been closed due to COVID-19, 27% said they were already opening, but a worrying 50% said that they were due to open but had no plans exactly of when the service would reopen. A further 21%, as you can see here, said they were not sure whether the pool was going to reopen or not. For those that weren't sure or said that their pool was not going to open, in the majority of cases, this was due to the government guidance regarding social distancing and cleaning requirements that would be required for a healthcare setting. So very often we see with hydrotherapy services, old facilities whereby social distancing would now not be possible. Also importantly to highlight, in some cases, it seems that the hydrotherapy pools are still unable to be opened due to these areas being used as storage or office space during the COVID-19 pandemic. Also, and is still the case in some of the areas local to myself, we find that physiotherapy staff have still been redeployed to support other clinical areas. In areas where their pools were due to reopen, it seems that in the majority of cases, again, the delay to opening is due to the social distancing and cleaning requirements that would be needed in place to open to patients again. Interestingly, in the data we saw also, though, that 12 facilities answered this specific question, that their hydrotherapy department was still being used by other services, as I previously mentioned, for example, as office space or storage space. In other answers, the most common reason for delay in opening again was related to social distancing and the ventilation requirements for a service. For those services that were able to say when they might open, the majority of these were due to be in autumn of this year, but nearly 40% said that they did not have a date to open, and 6% just stated that they would be open post-COVID. One of the questions we also asked was whether the services felt that they would have a reduced capacity as a result of reopening after the COVID pandemic. And unfortunately, 94% of the services said they would see a reduced capacity. To put this into context for you, we asked them what their normal capacity would have been pre-COVID. And as you can see, there was quite a variety in the results, anywhere between 50 and 400 patients being seen in a hydrotherapy unit. In response, though, the average capacity for the hydrotherapy services to restart after COVID was 37% of their pre-COVID level. It's important to highlight, though, that this was variable across the units, with some services saying their capacity would be as low as 12% or as high as 70%. This reduced capacity, again, was due predominantly to the social distancing regulations that were required and the space available to them in their hydrotherapy department. I think it's really important in the context of this presentation that we understand that hydrotherapy units are used by multiple different patients and different services throughout healthcare. On average, 8% of users of hydrotherapy services were Axial SPA patients, a significant number. But as you can see here, there are many different patient groups and that use hydrotherapy pools across the United Kingdom and therefore have benefit for many different healthcare disciplines. So in summary, people with Axial SPA highly value hydrotherapy treatment to help them manage this long-term condition. They make up 8% of our users, but 46% of physiotherapy services state that they have barriers to offering hydrotherapy to this patient group. Worryingly, in 2018, 1 in 5 pools were under threat of closure, and a further 3% of pools are now saying that they may not reopen post-COVID-19. 21% of services, whilst wanting to open, said that they did not know when they would or if they could in the current COVID-19 pandemic. So access to hydrotherapy is needed for all Axial SPA patients local to them. A joint voice is needed across all different charities and disciplines and healthcare services, not only for the Axial SPA patients, but for the wider patient population in the UK who may use our hydrotherapy services. Investment in NHS hydrotherapy pool facilities is needed across the NHS to make sure that they can continually run in an effective and an efficient way. The provision of NHS hydrotherapy facilities across the Axial SPA community and wider population of patients who access our services needs to be a priority in any hospital redevelopment. Thank you for listening.
Thank you, Claire, and thank you for a very powerful presentation with some very strong qualitative evidence there, and for taking us through the detail of that FOA request. We now come on to our fourth and final speaker of the afternoon, Natalie Beswetherick. Natalie is the Director of Practice and Development at the Chartered Society of Physiotherapy. Natalie.
Good evening. I'm pleased to be here. As you've just heard, I'm Natalie Beswetherick and I'm Director of Practice and Development at the Chartered Society of Physiotherapy. The Chartered Society of Physiotherapy is a professional body for the 59,000 physiotherapists, physiotherapy students and support workers in the UK. Hydrotherapy, now frequently called aquatic therapy, has been part of the scope of practice of the profession for decades. CSP has a dedicated professional network of specialists who actually specialise in aquatic therapy. It's important to note that this year, following the closure of all the pools in the UK during the COVID lockdown, this specialist professional network worked with PHE and local government leads to ensure that pools could reopen safely for patients and themselves. Hydrotherapy is beneficial for people with axial spa to manage pain and maintain improved function. You have already heard from Peter and his personal experience of losing access to his local hydrotherapy pool. Hydrotherapy is also beneficial for many people with long-term conditions, including a range of inflammatory arthritises, which affect children as well as adults. Access to hydrotherapy services remains a postcode lottery for many people. Where these services are present, it is more likely to be due to a moment of history rather than assessed population need. In more recent years, NHS hydrotherapy facilities have been in the firing line for closure as provider organisations seek to reduce costs locally, believing these facilities can be costly to run and be inefficient. The CSP has identified key learnings from our campaigning keep a range of hydrotherapy facilities open. The first is the need to work in close collaboration with patient stakeholder organisations such as NAS. In addition, clinical experts from the Aquatic Therapy Association, local staff and patients, as well as wider networking in the community. Engagement with local MPs can be also helpful. We have found that the patient voice particularly is heard much louder than a professional's. Then there's a topic of equality impact assessments. Frequently, we find that these have not been done. And where they have been done, they are superficial with little underpinning evidence of the method of assessment of the impact of a closure on specific patient populations. You do need robust evidence to challenge any proposals for closure from a range of sources. This includes robust research evidence of its effectiveness for those specific patient populations, which we have heard from Carol. Evidence can come from national guidance and guidelines, from NICE or SIGN, the standards, national standards for maintaining and managing hydrotherapy pools. You can find evidence in government commitments, for example, England's long-term plan and other commissioning priorities. To challenge the argument made of pools being inefficient or costly to maintain, you need to provide evidence how other hydrotherapy pools in the UK have maximised their use for the facility to cover costs. Making a successful case requires all these elements, but it does not guarantee that you will win the day. So what would good look like for hydrotherapy services in the future? Well, the first and most important is actually thinking about the people who have tremendous benefit, the patients. So for the patients for whom hydrotherapy supports them to manage their long-term condition, they should all have access to that hydrotherapy facility locally. I would think that being successful is seeing a massive reduction in the postcode lottery that there is today. We will see that pools can be highly efficient and income generating. And I think in terms of a call to action, what would be great to see is commissioning guidance being developed so services are available to meet the local population needs across the country. Thank you very much for listening.
Thank you, Natalie, for that very useful presentation on where we go from here. And I'd like to thank all 4 speakers this afternoon for providing such insightful and interesting, thought-provoking presentations. We're now going to go to the next stage of this afternoon's APPG meeting to open the question and answer session. And I will invite all the attendees to submit questions or comments they have in the chat function that they can see hopefully next to me on the screen, which we can put to our speakers. And our speakers will now, through the medium of this software, be moving onto the stage where they will be joining me and be able to take the questions, which will be facilitated by Dr. Dale Webb, who may or may not be joining me.
Tom, can I go and come in now? It's Derek Thomas. Can you hear me?
I can indeed. Hi, Derek.
Tom, you're doing a fantastic job, and I think we should make this formal. So, hi everybody, and thank you for coming along, and thank you also to the speakers and to Dale and to Simon. I was late. The reason we were voting, so I don't know quite how, Tom, how you got in there so quick. I must have dawdled. But actually, I've been chairing this group for maybe 18 months or so, and it's been a great honour. But when I met Tom and understood his experience and his expertise and his commitment to this subject, which is so certainly, I don't have the inside knowledge and the experience that Tom has. I was keen for Tom to take over the baton from me, and Tom is keen to do that. So we need to formally nominate, which I'll do, Tom Randall to take on as chair. I will absolutely, Tom, continue to be committed to this and support you and do whatever's needed. But to co-chair with Lord Campbell-Saviour. I understand that the parliamentarians who have already been part of this discussion are in support of this. Usually we'd be in a room and we'd vote, but obviously you can't do that. So I'm going to formally hand over to you now as the new chair. Congratulations. It's a really great honour, and you'll know already that Simon and Dale are worth working with. But thank you, Tom, for being willing to do that. It's a great subject, and I've got constituents who've come forward to give me their experience and their understanding and their challenges. And so I will continue to join and support you in making sure that we do accelerate the diagnosis and the treatment going forward. And even as we go back into lockdown, that somehow we keep an eye on how services may remain available to people and not be pushed to one side and delay things further for people. So thanks, Tom. I'm going to say no more. I don't want to delay the meeting further. And congratulations.
Well, thank you, Derek, and it's an honour to be elected co-chair. And thank you also, Derek, for your support over the last couple of months. I've been elected in fortunately a very quiet year for events, and so as I've been sort of getting my feet under the table since my election last year, Derek's been very helpful in giving me a steer on in terms of how APPG is run and the work that's been going on. And as you say, Dale and Simon have been fantastic, and I've had some initial successes. I think we had an adjournment debate in September about late diagnosis of axial SpA, which was very well received. by the minister. And also I had lots of feedback from around the country, people who wrote in to talk about their own stories about late diagnosis. So I do appreciate there's a lot more work to be done. As someone who has AS, I guess I've got some insight into some of the things that people have been going through and the treatments that are available, and very happy to spend the time that I'm in Parliament to do whatever I can to make sure that those who are coming in after me, as it were, getting diagnosed, getting treated, get the best treatment and diagnosis available. So very happy to be on board, and I say thank you again for your support. And as I say that, I'm official. I am now slightly lost as to how the software is working. So I'm hoping I'm going to be joined on stage by Dale, who's going to, and the other speakers, who are going to help with the Q&A. And here they are.
Thanks so much, Tom. And before we begin the Q&A, can I just first of all take the opportunity to thank Derek, because actually Derek and I first met a couple of years ago now and talked about this APPG and what its focus might be. And Derek's leadership was critical to establishing it in the first place. So Derek, thank you so much. Your role really has been instrumental. I do want to thank you, Tom, actually, because for all of us watching the parliamentary debate recently about delayed diagnosis that you led was a watershed moment, actually, really. And I want to thank you for the role that you're playing and help us to raise significantly greater awareness around a range of issues in AXPAR, including the question of delayed diagnosis. So thank you, Tom. So we're now going to move to a question and answer session, and we've posed 3 broad questions to try and structure our discussion. The first is about people's experience of services and how it impacts on the management of their axial spa. Then looking at examples of best practice in supporting these services across the country. And then asking the question, what support do local services and commissioners need to achieve improved provision, both during the pandemic and beyond? And during the course of this discussion, I will be queuing various people to join us on stage for the discussion. But I want to begin with this first question, which relates to Poppy's question in the Q&A about the NICE guidance and the lived experience. Can I please invite onto the stage Peter, our first speaker, and also Roger Stevens from Portsmouth. Just give them a moment to join us. And hopefully Roger. Wonderful. Thank you both for joining us on stage. I think in the meeting so far, we've heard a disconnect between, on the one hand, we heard in Carol's presentation that when the NICE group considered this whole question, they were doing so with very low quality evidence. So we have that on the one hand, and on the other, the lived experience of people with axial spa. And Peter, you said in your presentation that you live with pain almost constantly 24 hours a day, and yet hydrotherapy gave you respite, and that respite was significant. And I'm just struck by how wide that disconnect is between the formal research evidence and what people with axial spa tell us. Peter, how important do you mean in those moments when you really are in such prolonged pain, how important and significant is hydrotherapy to your life?
I think it's very important. Well, was very important. You know, it not only was it helpful physically, because it got you moving in a way that you weren't putting your body under too much stress. You were supported in the water, which you don't have on land. So it allowed you to build up mobility slowly and in a controlled manner, which isn't always possible in land. But on the mental side, which is something that I feel is completely overlooked a lot of the time with chronic illness, it was just having that feeling that you were doing something to fight back, which, you know, before diagnosis, and I couldn't move, was laying on the floor. You know, you don't know what's going on. Your mind's just all over the place, and you want it to do something to feel like you have control. And hydrotherapy gives you that bit of a route into doing that.
Thank you, Peter. And Roger, in Portsmouth, there's been a very strong group of axial spa patients who've used hydrotherapy services there. From your perspective, what do you see as the benefits that hydrotherapy brings to people with axial spa?
Well, at first I was a cynic, shall we say. When I first went along, I went along because I was told I must, and I wasn't looking forward to it. But when that was in August 1996, and to be honest, as I tell many people, it changed my life. It suddenly gave me freedom. It gave me confidence. It gave me a place where I could exercise without so much pain, and I began to look forward to that particular part of my week more than anything else. And if I was hurting, as Peter was saying, or your mobility was bad, it was something that really, really helped. I would loosen up. I would get my balance better. I could walk better. Everything was better, as simple as that. It was warm. It was easier to exercise. You could work harder because of the weight-bearing facility of the water. It really was an amazing change for me. And from 1996 right the way into lockdown, every week that's where I'd be. Come rain, come shine. It was a crucial part of my management of the condition. I can't imagine. It's been awful without it. Absolutely awful without it.
And let's explore that in a moment. But of course, for some people who can't tolerate land-based exercise, hydrotherapy is their only means of relieving the pain and their symptoms. So this whole question of people in flare in particular, who most of all possibly need hydrotherapy, what's your experience, either of you, of being in flare and the role that hydrotherapy plays in those moments?
Peter, do you want to go first?
Yeah, sure. Well, my experience was that when you're in flare, you don't want to move. All of your muscles tighten up and it tries to hold you still. So trying to get moving without having that warm, relaxing hydro pool was more painful and could actually make things worse. Whereas in the hydro pool, the warmer water gently relaxes you, allows you to gently start mobilizing slowly, because it's the movement that helps that body then get going. Because everyone with AS and Axpar know movement helps the condition. So you need to get moving as soon as possible. And through that and through the movement, it helps shorten the flare, which means there's less damage done. Yeah, so that was my experience of hydro with the flare. So it just shortened it and helped me through.
And of course, Roger, we're now in a lockdown situation and with COVID. So what can people do right now? For people who urgently need hydrotherapy but can't get it because of the current situation, what else can people do with Axial Spa in this kind of context to alleviate their symptoms and manage themselves?
Well, as you said, we've got a big group here in Portsmouth. We run 4 groups of 56 people altogether, and everybody was struggling badly in the first few weeks. But thanks to our excellent physiotherapists and led by Mrs. Jeffries, who spoke earlier, we now have a weekly Zoom session where anything from 12 to 27 of the group come on, and the physio takes us through a variety of stretches, and mainly stretches, not so much CV. And that helps. It's not the same though, because you are weight bearing out of water, but it does help. And we've got a lot of people who keep on coming back every week. We're into our 6th month now of doing weekly Zoom sessions, and it helps the group keep together. It helps the camaraderie, the team building. One of the crucial things about the hydrotherapy was you were with people who knew your condition, who understood you. There was no judgment. Everybody was together, and that with the Zoom sessions, that can help as well, because you're still with those people, and you can still keep the contact and keep encouraging each other, which has been such a crucial part of the whole experience.
Absolutely, but of course, without having hydrotherapy itself, for some people, I mean, whilst the camaraderie of Zoom is great, the actual physical and mental health benefits that Peter was describing simply aren't there, are they?
No, they're not there. I've certainly found for myself that it has been a very challenging last 6 months, and I'm drinking more which is possibly the only thing that I've noticed the big difference. I'm probably about tripled my alcohol intake as a way of getting around things. But yes, I missed the pool very badly.
Well, thank you both very much for your comments. If I can just now release you from the stage, and I'd like to bring on some further colleagues for the next part of the conversation, please. If we could bring on Rachel Lewis, who's a physiotherapist in Bristol, Colin Beaver from Portsmouth, and also Jacqueline Patman, please, from ATACP, which is the Aquatic Therapy Association for Chartered Physiotherapy. Just give them a moment to arrive. Wonderful, we're almost all here. Okay, let's start. Maybe Colin will join us in a moment. So I want to consider this question about best practice and making the business case locally. And I was struck by a comment in Natalie's presentation. She said, access to hydrotherapy remains a postcode lottery. Provider organizations seek to reduce their costs locally by believing that doing so, believing that these facilities can be costly to run and inefficient. Yet we know that many hydrotherapy pools thrive and have made their business cases locally for why they're so important and can be run efficiently. And so let's just hear really about some positive experiences. How do you make that business case locally, and what's been your experience? Rachel, can we come to you first, please?
Yes, I suppose initially hearing Peter talk about his 6 hydrotherapy treatments per year is very, very disappointing. And that's something that is across the UK and isn't unnecessary. And it comes down to our clinical specialism to discuss with our own managers and our commissioners what they're willing to provide. So I spoke to my manager, who said I could have 4 or 5 sessions for all of my patients for all of their care. So I said, thanks, I'll have 4 or 5 sessions per joint, thank you. So with that, then I said, what we're doing is we're keeping patients out of GP practices, we're keeping patients out of consulting clinics. And so with all of that, we're saving a lot of money, not in the physiotherapy service, which to be honest is peanuts within the medical professions of finances. We're keeping it out of much higher, more expensive costs. And we're also highlighting those patients for biologics much sooner. So then these patients are getting a better quality of life. They're back out there working within the community and everything as well. So lots of things can be used for that. So I say we treat patients according to their own individual need. And with that, we often use a lot of group work. So as well, along with NAS, we do a lot of group work within the NHS because of this camaraderie. And then sometimes patients, we can tell them the same thing till we're blue in the face. Another patient says the same thing and they listen to it perfectly. So there are lots and lots of ways of getting the same message across to patients. By treating within the group is obviously very cost effective for us. And also we can relay a lot of information about self-management as well as that treatment skill. We're also, as they mentioned, they're not getting their cardiovascular fitness. So in the pool, you can use a lot more cardiovascular fitness, because especially those patients with hip involvement, they can't move as much because of their pain, whereas in the pool, they can do a lot more. So again, hopefully, we would like to do the evidence and have the funding for research for that, to then provide that we're keeping them away from heart attack, stroke, diabetes, all of those other costly effects to the NHS services. So hopefully by keeping them treated and teaching them how to look after themselves, then they can benefit greatly. So there's always patients that will look after themselves and others that will need the support of NAS on a regular basis, and those that come in and out of the NH services. So we provide a helpline service to our patients, so they can ring that, they speak to our nurses, who then gets in contact with any member of the rheumatology service to contact them and support them. And within that phone call during Corona or the first few weeks of COVID in lockdown, our patients would ring the helpline, and they were often speaking to a specialist nurse, a physio, and an occupational therapist on the first day, and within a week a clinical psychologist. So if we can offer that kind of service on a more regular basis, because what we did was we stopped all our other work and we just did our helplines and nursing patients, then we can prevent these patients becoming more long-term and coming out of their employment statuses and that as well.
Okay.
So,
thank you, Rachel. So Jackie, when you hear Rachel speaking, we think about how we make the business case. On the one hand, we've got limited evidence from the studies that were reviewed by NICE. On the other, the kind of real world evidence that that Rachel's talking about, and building the evidence base. How strong, how easy is it to make the case locally that hydrotherapy services are effective and can be run efficiently?
Not easy, really. I think that in a clinical practice, we have very little time to take research. So what we have done locally, I worked in the NHS. I just retired, actually, just as lockdown started from the NHS after 34 years. And I'd set up 2 services for Axial Spa, one in Bristol in the late 80s, and then one in Sussex in the early 90s. And both of those groups are still running. And the fact that you have people attending groups for over 25 years shows that they are keen to keep that. The clients or the patients go with what they know works for them. And we've talked about the physical benefits and also the sort of psychological and mental health being benefits, but we haven't really spoken about the physiological benefits of immersion. And when our group in Sussex had an issue around whether they wanted to keep the gym group or the pool group, they really wanted to keep the pool group because they found it more beneficial. We set up groups, but obviously it's trying to collate the evidence and get the evidence through to the higher levels. And with our service, we've done MyMOP outcome scores, which is measuring your own medical outcome profile, and a JAM score, which is just a minute quick, how was your found your service, did it help you, that sort of thing. And we presented those about 5 years ago, and I've just actually managed to get a final year physiotherapy student to recollate that sort of data. I think it's not just it's a lot of long-term conditions, and I think I've been a member of NAS ever since I qualified as a physio in 1986, and it's a very good, strong, supportive charity. And if we can work with charities and with like the special interest groups, so the ATACP, the Aquatic Therapy Association of Chartered Physios, to actually make a network that works. So they might come into hospital for acute services, and so obviously in Bristol and in Portsmouth, they do have very strong physiotherapy intervention at that level, whereas lots of other hospitals don't have specialists in rheumatology necessarily. So they might be going to somebody who's not trained. And then there's a training issue as well around aquatic therapy. The ATACP set up foundation training so that people, when they qualify from to get their degree, they haven't necessarily had any experience in aquatic physiotherapy. So there's a training issue within the profession itself. And there's an importance then to make sure that the intervention that's given within those sessions is appropriate to the needs of the client. And I think that could be where on Carol's presentation, it said passive hydrotherapy. Passive hydrotherapy isn't going to work. It needs to be very specific and focused hydrotherapy by trained people in order to get that message across. But I also think there's a need for the NHS can't take this on board itself, and we need to work in conjunction with other agencies like Swim England and Good Boost, where they work with fitness industry to actually train fitness instructors, where there might be a bit more of a crossover from the health service into the fitness and leisure. And the other thing that we talked about was in rebuilds and the possibility of hospitals closing when there's a rebuild, that the pool always gets sidelined to one side, and then, oh, we will build it in the second phase. The second phase never happens. And I think part of that is during the time I've been a physio, the hospital today has decreased massively. And we used to have a lot of inpatient rheumatology and orthopedic patients coming down for aquatic physiotherapy. Now the hospital stay in general may be different post-COVID, because we'll obviously have a massive post-long COVID cohort to deal with, along with our other long-term conditions. It might be, so with the rebuild, it becomes that we're trying to provide a primary service in a secondary building.
Okay.
So the secondary people say it's not our deal. Okay, sorry.
No. You've given us a lot to think about there, really. And Claire, from your perspective, really, I asked Jackie the question: is it hard to construct the business case for hydrotherapy services locally to NHS managers? What's been your experience?
Yeah, I totally agree. I think it can be really hard, and unless you've got a really supported operational manager and trust on board, then it's a really hard struggle. And so I think I'm just very, very fortunate where I am in Solent to have a really supportive manager and trust. And I think you might have seen on the chat, I try and really keep our profile really high locally about our hydrotherapy service. So I'm constantly emailing our comms teams, our exec board about what we're doing in hydrotherapy, just to really try and keep that profile really high. And I think that's paid dividends with us being able to reopen during COVID, because they see the value for the whole cohort of patients, not just AXPAR patients. So trying to keep that profile is really high, but perhaps, as Jackie said, as clinicians as well, our job is with the patients. As I said to you before, Dale, our elixir of life is being with the patients and treating the patients, and having that time to keep that profile high, to do the research, to pull the business cases together. When we trained as clinicians, it can be a real challenge. So one of the things that Natalie was saying about trying to build business cases, it's a direction perhaps that the APPG could look at, and we could support physiotherapists to do, is to understand how to build these business cases and to push services forward.
And certainly it's the case, isn't it, that we don't have a large number of clinical academic physiotherapists who have a potentially critical role to help build that evidence base.
Yeah, I totally agree. Clinical academic roles in hydrotherapy, I think, could be really powerful. So you'll have clinicians who are working in clinical practice, but also contributing to research, putting research proposal forward. So we can try and build that evidence base, but with clinicians who are perhaps working at grassroots, who know and understand the patients and know perhaps what research we need to look at and how we can actually implement that with the patients themselves.
Well, thank you all very much for your contributions. If I can now release you back into the chat area. And as we now move on to think about implications, really, and how we support local services and commissioners, can I now invite some other people onto the stage, please? If we can first bring back Natalie, who spoke earlier, and then if possible, I'd like to bring up Leslie Kay, if she's available, and Sarada Chunduri-Shoesmith from NICE, and Andy Bennett, the National Clinical Director for MSK Services. If you're available and willing to join me on stage, that would be wonderful. So if we're able to bring any of the others up, that'd be wonderful too. Leslie Kay, Sarada, and G. Bennett. Perhaps while we're waiting, Natalie, I was again struck by another comment you made in your presentation about undertaking so during a consultation process to close a hydrotherapy pool, there's an obligation to undertake an equality impact assessment. And you said often they're superficial, with little underpinning evidence of the method of assessment of the impact of a closure on specific patient groups. It's quite a shocking statement, really, that such scant consideration is being given to the equality impact assessments of potential closures. How widespread a problem do you think that is?
I don't know how widespread it is, Dale, but my experience, I'm thinking also about the Bedford experience that Peter spoke about earlier on, is that there was inadequate assessment. In other words, all the patient groups that would be affected adversely by a major decision, and closing a service for some patient populations is a big decision. And the scrutiny committee need to be assured that they have actually undertaken an adequate quality impact assessment. But frequently we found when we've been approached by services to say that a pool is under threat, I normally say the first thing is, have they actually undertaken one? And by asking the question, we find that no, they haven't. So you can often draw a stop to them progressing any decisions, because they need to go back and actually do the work that is required, it's mandated, that it is actually a full assessment to look at the impact of a closure, which is taking away a service from a particular patient group. And certainly in my past, when my local hydrotherapy pool, which was part of my service, was under threat, we utilised patient groups who had not been contacted. They had not been contacted by anybody about their service being taken away. And the trust board suddenly woke up to this, that assessment hadn't been done. So it's really part of that, when you're making that business case, or you're involving yourself in a consultation because you want to fight it, always check and see what has been said or done to see if there actually are any holes in what they've done. And frequently, I think people are saying that it hasn't been done, or it's really had scant regard paid to it.
Thank you, Natalie. And we also heard in Peter's presentation, in his case in Bedford, that the council's health overview and scrutiny committee hadn't even been properly consulted. So it seems that insufficient attention is being given by decision makers to potential closure of hydrotherapy pools. I'm joined by more colleagues who want to, I'm sure, to contribute to this. Dr. Chan, first of all, what's your take on the current provision of hydrotherapy services and how we better make the case to protect those services?
I think the important thing is being joined up, that the service will benefit our patients with axial spondyloarthritis, but there are also other groups who we know use the hydrotherapy services as well. So a case can be made in a more joined up fashion with other groups of patients, and it could be a uniform case to show the benefits that the pool can be used for the whole days within the week, for longer hours. And that would be a better case for us to make as a part of an overall MSK strategy, and also to look into the other specialties as well.
Thank you. I know that Tom has to leave for another vote in a moment. Tom, is that correct?
Yeah, the minister's on his feet. You'll hear a bell go when I get summoned. So it's all summoned by bells around here. So I'm here just for the.
Okay, great, thank you. Dr. Matsu-Ortega, you're also chair of Brit Spa. What's from your perspective? What's the health of hydrotherapy services for Axial Spa, do you think?
Well, I think, unfortunately, I do agree with everything that has been said up to now. And, the health of hydrotherapy is just not good at all. And it hasn't been for a very long time. I mean, I think if I give you an example from our trust in Yorkshire, I work in Leeds. We do provide care for a tertiary population of nearly 4 million. And there are not many hydro pools around. The one that we have in Chapel Allerton, which was specifically built for people with rheumatological conditions and primarily rheumatoid and axial SPA, has been going through, recurrent closures and periods in which there were not enough staff to support them. And, it's always been a long-standing saga. I mean, I think I do agree with what's been said. I think the patient voice is absolutely essential here. There's never going to be a piece of research that is going to show that water-based exercise is going to change a disease at all, but it definitely can provide, the amount of relief enough, to keep people healthy, not from the physical, but also from the mental point of view. And I have added some comments on the chat. The Romans found this out very earlier on, didn't they? And water-based treatments are absolutely essential for many diseases, not only axial SPA, and that is still on prescription in certain countries in Central Europe. I mean, the fact that people with axial SPA get so much spasticity and muscle contractures, and, the first thing that goes in the back is not a structural problem within the bone, is, the hypertonicity of the muscle around the bones. And this is why, water-based exercise works. It's absolutely beautiful, you know, to be able to have the possibility of stretching those muscles without pain and against gravity. I've mentioned maternity services before. Maternity services are big users of pools. And I think, you know, joining together neuro rehab, you know, neurology, respiratory, there are many, many services. There's no reason why this work could not be won if everybody pulls in the same direction.
Thank you. I want to reflect on the question that's been posed by Dr. Bernstein about NICE and the whole issue of cost effectiveness and the threshold. He's saying, what is the cost effectiveness in the UK population of hydrotherapy, and how certain are we that it's under the 20,000 per QALY threshold? Do any colleagues here know the answer to that question?
No, I don't know whether it's been looked at that. I don't think there has been much cost economic data, you know, around hydrotherapy. Certainly, I have not seen it.
So I'm seeing heads shaking all around. So I think the answer is no. And I think Carol did refer briefly in her presentation to the fact that there have been few studies looking at this. So again, I come back to this disconnect between the lived experience of people with axial SPA and other conditions for whom this is, you know, a very significant part of their management. We know that we have got, I think no, excuse me, no RCTs that have looked at impacts beyond 6 months, and no long-term studies whatsoever. And I wonder how we get beyond that disconnect and try and create stronger scientific evidence about the impact and indeed cost effectiveness, as Dr. Bernstein is asking, of hydrotherapy.
Well, I think if I may say something here, there are data coming out, you know, with studies on muscle function in axial spondyloarthritis. And I think there are some projects going on looking at, you know, the muscle in the early stages of axial SPA in particular, and looking at the way, you know, muscle behaves and, you know, the response to pain is actually extremely important, because as I said before, you don't need to be able to show a life-changing, you know, benefit. It's the same as when we give paracetamol to treat pain. Nobody has done a study to see whether paracetamol is going to decrease your chances of having a heart attack. Yet, everybody agrees that it's actually a very good short-term remedy if you are in pain. In the context of, you know, muscle involvement and pain coming from muscle or bones, you know, it is proven that in the short term, water-based exercise works. And I think it should be treated as such. It's just much better than, you know, taking painkillers, if you ask me.
Thank you, Helena. Carol, welcome back to the stage. I'm sure you're going to have some perspectives on this question.
Yes, I did post in the question answer to Dr. Bernstein's question that NICE had done their own sort of exploration of the costs, and when there was a pool established and being run that was very cost effective as an intervention, there were no concerns. You can't make a recommendation, or it's very difficult to make a NICE recommendation when the quality concerns are cost concerns. So we were able, it was very strongly supported, and there wasn't considered to be any significant financial impact by providing hydrotherapy to people with AXPA.
And again, listening to this conversation and thinking about the inadequacy of the current evidence base, the lived experience, however, but also the ability of some trusts to mount their own business case internally. What do you think next in terms of this question, going back to NICE as a consideration? What do we need to do to have another conversation about this with NICE?
NICE at the moment, although it is more commonly adopting experience-related data and qualitative data, we really need the research. We really cannot begin to emphasise how important it is for us as a group of professions to get together, and it's something I've been trying to work on, that we get together and we just get observational data and we get all the people in our pools to respond to that. We can, if we could get a research-funded NHR-adopted study, trusts will be really pleased to support that research, because when they recruit into studies in a trust, and certainly it's an easy way to run a study, an observation study, it really will be supported. It will be supported by trust R&D studies. So we just need to work out some funding to support some robust research to use this great resource we have, all those pools that are still open. I guess in the COVID situation, maybe we can do a retrospective study and use it to look at patients' experience. So, but really we need research for NICE to be able to help us make any kind of very strong recommendation.
And so maybe a recommendation from the APPG meeting is to develop a research strategy for hydrotherapy to address the key questions that will need to be satisfied for NICE to make a change to its current guideline. But I guess part of our, please, Natalie, come in.
I'm just thinking, I'm just listening to the stories from two patients with Axial Spa this evening. There may be an opportunity, you're talking about observational studies there, Carol, about looking at the increased medication that has been necessary for patients with Axial Spa while they haven't had a service, because you could do that like a retrospective about, has there been an increase in whether that's in pain medication or other medications that Peter and his colleague actually mentioned about, what else is changing. And that could be done at a very local level, and sometimes by starting just a small scale piece that can then build maybe a useful way forward to inform something much more robust.
Yeah, very much so, absolutely. So I guess we'll draw to a close in a few minutes, but obviously in the current context of COVID, and echoing your comments earlier, really, Natalie, about postcode provision, what we don't want is COVID to be used as an excuse to quietly not reopen large numbers of pools. And we saw from the FOI results that Claire presented that indeed many trusts don't have a plan at present to reopen their pools. And I wonder whether that creates alarm bells for any of you and what you feel we might need to do about that.
I think the important thing is that we
for the CS. Sorry,
we have in the short term they're looking at direct costs. There are also a lot of indirect costs of not having the pool. So, as you say, people might be using more of the other services that are being used, GP services, medication, longer length of stay. So these are the things that when we want to look at robust data, is to be measuring these indirect costs, or as a result of not having the service, would be something that we need. And I think that's a good challenge to us, because when we ask for this data, often that's where we struggle to defend the case, because we don't have this data. We don't have a randomized controlled trial. We don't have the same level of evidence in terms of the levels of evidence. So what we've been asked today about quality and all this is a good challenge for us as a community to come together to design a properly well-designed study to actually once and for all, beyond the narratives, beyond the personal experiences, to get some objective data for this.
Wonderful.
I think one of the angles here, Dale, that will be a winner is looking at the impact on mental health that access to hydrotherapy has for our patients. And answering your question, what do we think COVID is going to be? I think it's going to be a great excuse not to run back to reopen, particularly because we're going to face significant shortages in the staff. And not everybody, within the physio teams are either trained or willing to be part of the hydrotherapy, regular staffing, members. And if we know, or if we think about the prevalence of mental health issues that our patients have just by virtue of having a chronic inflammatory condition, and how this is going to be escalated, by the fact that we're going again into lockdown and COVID is going to be with us for still a long time to come, I think there is a very strong argument to survey or to try and measure the benefits that hydrotherapy can actually, bring to our patients in this front. And that will be absolutely non-contestable by the government, particularly if you have in mind that part of the 10-year long-term NHS plan actually contemplates the mental health of the nation as one of the main deliverables. So I think it will be really good, to put this into context.
That's a very, very good point in detail. Can I just perhaps bring Tom Randall back onto the stage? I think Tom is now back from his latest vote. Hi, Tom. Welcome back. I know you had to leave briefly, but listening to the parts of the conversation you've been able to listen to, what jumps out to you as being some of the key issues that the APPG ought to be concerned about?
Well, I think we've had a lot of sort of powerful stories, really, in terms of the difference that that hydrotherapy can make to people, and I think that qualitative analysis that we've had, the stories, the anecdotes that we've had have been really quite strong in terms of saying, look, this has really helped my flare-ups. Obviously, it sounded like from the presentations we had earlier, sort of perhaps more work trying to sort of understand how we can quantify some of that information. But I think one of the things I take from that is to sort of say, well, look, what's our local hospital doing? My local hospital's got a hydrotherapy pool. I don't know off the top of my head what the status of it is, but as the MP, I'm now motivated to go and ask, well, what's happening to it? When will it reopen? Will it reopen? And are we going to get patients back in that pool? So I think definitely, if you have got a hydrotherapy pool that you might think is under threat, write to your MP and get them to write to the hospital chief executive or the clinical commissioning group to get that pool unwrapped. I do appreciate that pools are expensive things to run, and I can see certainly we've had those conversations about hospital estates and things, and they can, I guess, can be a very attractive thing to lose as part of any sort of redevelopment. So yeah, we've got to keep that. I think it was a really powerful thing talking about how connecting with the comms teams in hospitals to show what they're doing. I think that was really, really, really powerful. I don't know who that was, I'm afraid. Sorry, on this little screen, but please do.
Sorry, I think that was Natalie, I believe.
Natalie, hi.
Yes, yeah, I was just while we're waiting for Tom, I think given the government is and stating how important rehabilitation is for a whole range of people, not just with COVID, long COVID, but a range of long-term conditions, removing people's ability to receive rehabilitation, whether that be in a pool or the other location, I think it's an ideal time to actually raise those particular points for this particular patient population. It's building on the lack of rehabilitation for a whole range of people, often with inflammatory arthritises and others, that the areas being closed that Claire talked about or not reopened is going to seriously damage the health of the population moving forward, not just physically, but also their mental health.
And I think that's a really good point. And I think the other thing that jumped out for me, and I know we shouldn't necessarily look at this in terms of pounds and pence, but that is naturally when you're running a spreadsheet or whatever, that is sometimes how these things are looked at. And there's that really powerful argument also, I think, about putting someone in a hydrotherapy pool stops them from going to a GP or using another service which is going to be expensive. And I think that is another really sort of powerful argument for these things. And actually, not only do they work, but they stop you going on to using other services which are going to cost even more money. And I think from this discussion, certainly from we've heard this afternoon, I think there have been some very powerful cases to be made for retaining and reopening these pools, and that's a case that needs to be made to those who can who are the decision makers, definitely.
Thank you, Tom. So let's perhaps just, if we can just release Tony, Carol, Natalie and Helena back. Before I can hand over to Tom to conclude matters, I want to say thank you for a really stimulating conversation. Some concerns being expressed here about this as an easy target for cuts, and the need for us to mount the arguments about the reason to maintain hydrotherapy services, as well as the need to strengthen the underpinning research, and that might require a whole new research agenda and funding in order to do that. But certainly I think vigilance, and I think the APPG keeping an eye on this, because if the threats to these services is as real as we think it may well be in the context of COVID and post-COVID, then that's something we want to keep an eye on. So thank you all very much, and I'll now hand back to our new chair, Tom, to conclude matters. Thank you, Tom.
Well, thanks, Dale. And Well, thank you everybody who's taken part this afternoon. I think it's really been a really informative session. I certainly know what my next question at Health Questions is going to be about. So yeah, I'll be getting onto that, and I look forward to working with Dale, Simon, and the team on the next pieces of work of the APPG. And I look forward to working with Lord Campbell Savers, who couldn't be with us today, and also with the other members of the APPG, particularly Andy Slaughter and Munira Wilson, who did intervene on me on my adjournment debate I had a little while ago. So I'm grateful to them for their support as well in Parliament as well. And as I say, look forward to working with Derek, who I'm very grateful for his support in the run up to today. As you may have seen, we had a vote earlier on in Parliament for some restrictive measures. So I know it's going to be a difficult couple of weeks. The nights are drawing in. We've got some more restrictive measures coming in, and I know it's going to be a very difficult period for everybody, but particularly for people like us who have got underlying health conditions. So I hope you keep safe and well over the next couple of weeks. And what better thing to look forward to beyond that period than the 6th meeting of the All-Party Parliamentary Group for Axial Spondyloarthritis, which will be coming up in 2021. So I look forward to seeing you all then, hopefully in a more physical form soon. But if whatever form we do meet again, I look forward to seeing you then. And thank you very much for attending this afternoon.